Mediastinal staging for lung cancer. Lung cancer is the most common cancer worldwide, with non-small cell lung cancer accounting for approximately 85% of all lung cancer tissue. Tissue biopsy for histopathological diagnosis and molecular characterization facilitates the accurate staging as well as classification into subgroups. For mutation-specific targeted therapies, mediastinal staging therefore plays a critical role in determining the appropriate treatment and prognosis for the patient with suspected or confirmed lung cancer. Several modalities exist for performing the mediastinal staging and are broadly grouped into minimally invasive and surgical technique. The selected approach is the initial guided by the clinical staging and determined by the contrast-enhanced CT or PET imaging. Lymph node more than 1 centimeter along the short axis and or PET orbit nodes with more than SUV of 2.5 are considered as potential targets. In brief, the N1 nodes are considered to be ipsilateral, hilar, peribronchial, or intrapulmonary. N2 nodes are ipsilateral, mediastinal, or subcarinal, and N3 nodes are contralateral, mediastinal, hilar, or supraclavicular lymph node. Invasive mediastinal staging is most often used for suspected N2 and N3 disease, the treatment with induction therapy or the definitive dose radiation therapy rather than in addition to surgical resection may be appropriate. In contrast, identification of the metastatic disease at any point during the evaluation obviates the need for the further evaluation of the mediastinum, as patients with advanced disease are not considered surgical candidates and instead should be proceeded directly to systemic therapy. Finally, the likelihood of lymph node metastasis is low for T1A and 0M0 disease, such that the preoperative tissue biopsy is typically unnecessary and the surgical resection with intraoperative lymph node evaluations is sufficient. So the lymph node stations could be supraclavicular. Station 1 is lower cervical, supraclavicular, and sternal notch, and biopsy the lymph node rather than the mediastinum. And the superior mediastinum is 2L and R, upper paratracheal lymph node. Oncological midline is defined by the left lateral border of the trachea. And there are also prevascular, retrotracheal, and lower tracheal. The azygous vein differentiate R4 from R4R. Then are the aortic 5 and 6, subaortic and para-aortic. Important for suspected left upper lobe lesion. Then inferior mediastinal 7, 8, 9, L and R. These are paraesophageal and pulmonary ligament nodes and can be assessed by EUS, and N1 nodes 10, 11, 12, 13, and 14. N1 node stations are double digit, and station 10 nodes are located along the mainstem bronchi and hilar vessels versus station 11 nodes that are located between the origin of the lobar bronchi. So there are various techniques which can be used. And most important is the minimally invasive technique, which can be utilized by using the fine needle biopsy or EBUS. It is the endobronchial ultrasound guided biopsy, and it is used to biopsy station 2, 4, 7, 10, 11, and 12. EUS is transesophageal endoscopic ultrasound fine needle aspiration, Originally designed for gastric esophageal cancer, adopted for lung cancer screening, and alternative techniques include transthoracic needle aspiration, TTNA, and conventional bronchoscopy may be used for central tumors, and navigational bronchoscopy is an increasingly available modality at select centers. Surgical approaches, no additional staging is required when the initial study positively confirms the highest stage suspected disease. Cervical mediastinoscopy. Historically, the cervical mediastinoscopy was considered to be the gold standard for the mediastinal staging and sensitivity of 78 and negative predictive value of 91%. The obvious benefit is direct visualization of the target lymph node, ensuring the adequate specimen volume. The VATS is provides direct visualization and access to thoracic cavity and mediastinum, and Chamberlain procedure is usually classical for left anterior mediastinotomy via the parasternal incision. It is important to remain outside the pleura and beware of the risk of the injury to internal mammary artery. So, in the minimally invasive technique, EBUS node stations which can be biopsied are 2, 7, 10, 11, and 12, EUS 2, 4, 7, 8, and 9, and cervical mediastinoscopy 2, 4, 7, and 10, Chamberlain procedure 5 and 6, VATS 4, 7, 9, and 1, and on the right side, on the left side, 5, 6, 7, 8, 9, and 1. So this is a process of shared decision making and is essential for increasing the life expectancy and making the right diagnosis. Thank you very much.